Hey. Yeah. Yeah. Okay. Hello, my name is Sherry Rees-Stevens, and I'm going to talk to you today about the RSV program here at Sick Kids and also with the Ministry of Health in Ontario. So RSV stands for respiratory syncytial virus. So I'm just going to go over some of the epidemiology to begin. So it's the most common respiratory pathogen worldwide. It's responsible for 50 to 90% of bronchiolitis, 5 to 40% of pneumonia. It infects 40 to 60% of all infants in their first year of life, and 85 to 100% are infected by the age of 2. Reinfection is quite common, and we have no adequate treatment that exists for RSV. So the RSV season here in Ontario starts November 16th and goes till the end of March of 2021, and this is determined by the Ministry of Health for Ontario. This is a slide, although it's from 2016-2017, it just shows the prevalence of RSV with infection rates over the year. So week 45 is the beginning of November, so you can see so the respiratory syncytial virus is yellow. You can see that it's starting to increase the number of positive tests. It kind of peaks around the end of December, beginning of January, where the highest peaks are less than 3,000 positive near the top, and it starts to decline usually by the end. So week number 15 is April 1st, and that's when we see kind of it starting to decrease in positive rates. So this kind of guides our practice in terms of when we provide prophylaxis for our infants. So palivizumab, that's a generic name. The trade name is Synagis. It is a passive antibody, and it's been approved for use in Canada since 2002. So it is a humanized monoclonal immunoglobulin. It is a passive immunizing agent with a highly specific antigen targeting F glycoprotein of RSV. So the F protein on the surface of the virus causes the proteins on the membranes of the nearby cells to fuse, creating syncytia. So just the mechanism of action. So it binds the F protein of the RSV. So Synagis is attached to the protein in this picture. It blocks the fusion of the infected cells, and overall it reduces viral activity and cell-to-cell transmission of the virus. So prophylaxis does not prevent children from acquiring RSV, but if they do, we just hope their symptoms are less severe, and this kind of demonstrates how they would be less severe. Our criteria has not changed for approval per the Ministry of Health. I just wanted to point out that different provinces and different countries have different prophylaxis programs. So in Ontario, this is our criteria that we've used for the last few years. So basically in Ontario, for them to be approved, they have to be a resident of Ontario with a valid OHIP card, and they have to meet the criteria that I've listed in this slide. I'm just going to review some of it quickly. So prematurity, if they're less than 32 weeks completed gestation at the start of the season, they would automatically qualify, and our start of the season is May 1st. Infants that are 33 to 35 weeks completed that have a risk score of 49 to 100 are approved, who do not live in isolated communities. And there's also criteria for infants that from 33 to 35 weeks who do live in isolated communities, and they would be approved if they can't readily access healthcare as needed if they were to acquire RSV. And also children that are less than 24 months of age with bronchopulmonary dysplasia and chronic lung disease who require oxygen. So these children are assessed on an annual basis. And for the cardiac infants, children that are less than 12 months of age with hemodynamically significant cyanotic or acyanotic congenital heart disease requiring corrective surgery or on medications for the heart disease. So in this population, it'd be a VSD and failure, tetralogy of Fallot, all our single ventricle babies, any cardiomyopathies with decreased function that are on medications, infants with pulmonary hypertension. So those are just some examples in that category. And then children 12 to 24 months of age with ongoing hemodynamically significant congenital heart disease. So those would be, again, our single ventricle babies that have had their Glenn. And then other cases determined. As well, trisomy 21, they're automatically approved up until the age of 2 for prophylaxis. I just wanted to make a quick note about multiple birth sets. So if a high-risk infant of a multiple birth set is approved for the season, then the siblings of that in the same set are also approved, because the risk of transmission between the multiples is quite high. I'm not going to go into the rest of the slide here. So I'm just going to go over the next few slides are from the impact trial. So this is back from 1998, and it really guides our practice here in Ontario and at Sick Kids. And so it was a big study done, and it really proves how effective palivizumab is in preventing hospitalization rates in infants. So in this slide, so the orange, excuse me, so for premature and infants with bronchopulmonary dysplasia and chronic lung disease, their hospitalization rate for infants that did not receive palivizumab was 10.6%, and for the infants that did receive palivizumab, the rate was 4.8%. So there was an overall reduction of 55% in hospitalization. So this is was very statistically significant in this study. As well, so just for BPD and CLD, hospitalization rates were decreased by 39% for the infants that did receive palivizumab. And hospitalization rates for children with congenital heart disease, and 9.7% who didn't receive palivizumab were hospitalized compared to 5.3% who received palivizumab, which is a reduction of 45%. As well, palivizumab serum concentration. So for infants that are receiving palivizumab prior to the cardiac surgery, cardiac repair, their serum levels are approximately 98%. When they go on bypass, it removes approximately 58% of the palivizumab from their system. So that guides our practice, and that's why we do give a post-pump dose after surgery as soon as the infant is clinically stable to have that dose. We have an interdisciplinary approach at the kids here for the RSV program. It includes nursing, pharmacists, and physicians. So the patients need to be identified first off for the RSV program according to the criteria I reviewed by the Ontario RSV Advisory Board. Parents or the guardian are approached and a verbal consent is obtained, and then we apply to the Ministry of Health. Also, during our discussion with families, we also go over education with respect to respiratory viruses, protective measures, and this is very similar to COVID-19 at the moment. So as I mentioned, our prophylaxis season goes from November 16th to the end of March. Every year, this is it's just changed slightly by the Ministry of Health. When they're approved by the Ministry of Health, it's for 5 injections, a total of 5 doses. But there's a potential to receive a 6th dose if they do need a dose after surgery and they need to continue doses for the remainder of the season, depending on what their congenital heart disease is. Here at Sick Kids, our default time to administer is 1800 because this is our common time to give enoxaparin. And if needed, if the baby is on enoxaparin, we would give the palivizumab just before at the same time as the enoxaparin when their trough level is low. Vials are never tubed here. We need to pick them up from pharmacy by the ordering unit. It's to be kept refrigerated. We administer immediately after drawing up. Ideally, we do change the needle after drawing it up. The typical volume limit for infants is 1 ml per site. If the dose is more than 1 ml in volume, then we would divide the dose into 2 syringes and administer at the same time. We'd label the syringe as required and apply pressure to prevent bruising after administration, 5 minutes. So in terms of when we give palivizumab and the recommended dosing schedule, so there is a potential for levels of palivizumab to fall below protective threshold between the first and second doses. And this is oftentimes when we see infection increase as well. So we give the second dose 3 weeks after the first dose, and then after that, it's every 4 weeks. The dose is 15 milligrams per kilo per dose, so it'd be day 0, and then we'd give it day 23, and then 4 weeks after. So the maximum number of doses per season is typically 5. Studies have not been done assessing prolonged dose regimens. We wouldn't give it now over the low risk season, and there's a cost consequence of ongoing prophylaxis during the low risk season. Initially, we were concerned about giving subsequent seasons, but the study has since found out to be safe to do so. So we do give second, sometimes third season, depending on their congenital heart disease. Just some frequently asked questions about palivizumab. What are the side effects? So the risk of palivizumab causing serious harm is extremely small. Life-threatening allergic reactions are very rare, and the most common side effects are fever, irritability, or redness at the injection site. So from my experience, it's mainly been more pain from the injection. And if they're admitted to the hospital, we will give them Tylenol after their dose just to help them with any irritability that they may have following administration. So why is it recommended that palivizumab dose number 2 be given at 21 to 25 days after the first dose? So again, the target serum trough palivizumab levels are not always achieved after just 1 dose, and therefore it's recommended that the second dose be given 21 to 25 days after the first dose, and the remaining doses are monthly. And how long before palivizumab becomes protective? This is again 48 hours after administration. It would start having effect. Nosocomial infections. So although the incidence is low, nosocomial RSV infections are a significant risk factor for severe RSV disease and have been shown to extend duration of hospital stay and increase mortality compared with community-acquired RSV infection. The immunocompromised, the complex patient who will shed for much longer periods, and therefore isolation periods should be extended as well. Things to remember when administering palivizumab. If your patient is receiving anticoagulation therapy such as enoxaparin or Coumadin, administration of palivizumab should not be delayed if the patient is clinically unwell or is receiving concurrent antimicrobial treatment or vaccination. So most infants here, we do wait until they're stable after they've had surgery before we will give them their post-pump dose. But otherwise, we do give prophylaxis while they're admitted in the hospital. For twins multiples, research has proven that it is important to prophylax all infants. And for pain management, there's local and oral medication, and guidelines are in our e-formulary here at SickKids. Does an infant who is RSV positive need to continue with the regular schedule for prophylaxis? So primary infection does not confer protective immunity. Reinfection is common, and there are 2 strains of RSV. There's RSV-A and RSV-B. So concurrent infections are not uncommon, and therefore patients who are infected with RSV should still continue to get timely prophylaxis when they are stable. What are the modes of RSV transmission? So it's a droplet or large particle. It requires close person-to-person contact, usually a distance of less than 0.9 meters for infection to occur, and ports of entry are the eyes, nose, and mouth. What are the incubation and shedding times? So the incubation period for RSV is 2 to 6 days. Infected children shed the virus as droplets in the respiratory secretions for 3 to 7 days, and shedding may occur for as long as 3 weeks and longer if the child is immunocompromised. RSV can spread by contact as well. So by touching mucus from the nose or mouth of a person who has the virus, by touching soiled tissue or surfaces a person with the virus has touched, by touching the unwashed hands of a person with the virus. RSV can live on countertops and other hard objects of more than 6 hours. It can also live on clothes and hands for up to half an hour. So this slide here just shows how long it lives on different surfaces that I went over. So obviously a hard surface with a countertop has the longest period of time. And this slide just depicts large particles large droplets in the air, so it can enter the eyes, the nose, or the mouth to cause infection. In terms of injections, for needle gauge and needle length, we usually use 5/8 of an inch for needle length, and I usually use a 25 gauge needle for injection. So you would assess that in terms of how big the child is that you're giving your dose to. Oh. Okay. In terms of where we give it in the vastus lateralis muscle, so the upper outer quadrant of the quadricep. That's the muscle that we use to give the IM injection. And regarding volume, so the maximum volume we can give is 1 ml to infants here. So if it is greater than 1 ml, we do divide the dose into 2 syringes and give it simultaneously. And for any support, you can reach me. Here's my extension. We do have an email internal for the RSV program. The pharmacists are very knowledgeable, the educator, the clinical support team, and nurse practitioners here at Sick Kids. And just wondering if anyone has any questions. Okay. Thank you.